Bismillah ar-Rahman ar-Rahim. Our subject is the evidence-based and guidelines of the preterm labor. It is from my book, Essential Clinical Practice Guidelines in Obstetric, the first edition. Preterm labor or premature labor is defined by WHO as onset of labor less than 37 weeks in a pregnancy, or less than 259 days of pregnancy, and beyond the gestational age of viability, which is 20 weeks of gestation. According to the American College of Obstetric and Gynecology, premature labor is considered before 20 weeks of gestation. According to the UK, before 24 weeks of gestation. According to the FIGO, the premature labor is considered before 22 weeks of gestation. The diagnostic criteria of preterm labor is considered according to the American College of Obstetric and Gynecology criteria, which are the presence of 4 contractions in 20 minutes or 8 contractions in 60 minutes, with progressive cervical dilatation and effacement. Cervical dilatation more than 1 centimeter and effacement more than 80%. If the cervix is less than 80% effacement and less than 1 centimeter dilatation, the preterm labor in the early stage. According to the cervical length, if the cervical length is more than 2.5 centimeter, it is a false labor pain. If the cervical length less than 2.5 centimeter, it is threatened preterm labor. When the cervical effacement more than 80% and the dilatation is 1 to 3 centimeter dilatation, it is considered early preterm labor. When the cervical effacement more than 80% and dilatation more than or equal to 3 centimeter dilatation, it is considered advanced preterm labor. The preterm labor is classified into early preterm labor between 28 to 31 weeks, late preterm labor between 32 to 36 weeks, and extreme preterm labor less than 25 weeks of gestation. The pathogenesis of the preterm labor. The keystone in the pathogenesis is the release of proteases, uterotonins, which will cause uterine contraction, cervical changes, and even premature rupture of membrane. The ultimate result is the premature labor. The risk factors for preterm labor are medical history, is the low weight for the height, obesity, uterine and cervical abnormalities, uterine fibroid, history of cone biopsy, this exposure as a fetus, chronic illness, cardiac, diabetes, clotting disorder, anemia, periodontal diseases. Obstetric history, previous preterm labor, previous first trimester abortion, previous second trimester abortion, incompetent cervix, cervical length 25 millimeter or less, and increase the number of embryos implanted in ART. Another risk factor in the current pregnancy as cervical insufficiency, preterm premature rupture of membrane, intra-amniotic infection and inflammation, placental abruptio, idiopathic preterm labor. And there are a risk factor in the lifestyle and the demographics. Age less than 18 or more than 40, low socioeconomic status, poor nutrition, smoking more than 10 cigarettes per day, non-white race, long working and standing hours. The dangers of preterm labor. 75% of neonatal morbidity occur in preterm neonates. These include CNS complications, cerebral palsy, neurodevelopmental delay, respiratory complication, blindness, deafness, GIT complication, cardiovascular complication as BDA, metabolic abnormalities, including hypoglycemia and jaundice. Prediction of preterm labor include risk scoring system, home uterine activity monitoring, cervical screening by transvaginal ultrasound, screening for fetal fibronectin. Fetal fibronectin 15 nanogram per ml is suggestive of preterm labor, and other tests for screening for bacterial vaginosis and other biochemical markers. Risk scoring system, including the socioeconomic factors, previous medical history, daily habits, medical condition if present. It is not found to be useful in screening of preterm labor. The home uterine monitoring activity. It is done by special external tocodynamometry. The contraction recorded twice daily. It is not readily available and costly, not found to decrease preterm labor incidence. The most useful and helpful screening tool for prediction of preterm labor is transvaginal ultrasound, cervical ultrasonography, suggestive of preterm labor, including cervical insufficiency and cervical changes in absence of contraction, including cervical length less than 25 mm and funneling with the internal os diameter more than 5 mm. About 80 to 100% of women who deliver early have a cervix shorter than 25 mm, and 50% of delivery rate within 1 week of those have a cervix more than 25 mm. The fetal fibronectin testing, it is the only recommended by the Royal College of Obstetric and Gynecology. Fetal fibronectin more than or equal to 50 nanogram per ml is suggestive of preterm labor. The sample for fetal fibronectin is obtained from the posterior fornix of the vagina, and it is indicated in symptomatic preterm labor between 24 to 36 weeks of gestation and intact membrane and cervical dilatation less than 3 cm. It is contraindicated in presence of rupture membrane, vaginal bleeding, cervical circulage in situ. One of the relative contraindications to obtain fetal fibronectin is after the use of lubricant or disinfectant or within 24 hours of coitus or vaginal examination. The other tests for screening. Screening for bacterial vaginosis and other infections, as urea plasma, gonorrhea, chlamydia, untreated urinary tract infection, and other biochemical markers include increased salivary estradiol, presence of high level of non-stratified fatty acids in serum between 9 to 20 weeks is indicative of higher incidence of preterm labor less than 34 weeks of gestation. The elevated albumin and vitamin D level in cervicovaginal discharge is a predictor of preterm labor. The increased maternal serum corticotrophin-releasing hormone is considered a risk for preterm labor. The increased antithyroid peroxidase antibodies related to preterm labor. Prevention of preterm labor. It is primary prevention, elimination of the risk factor. This is by improving maternal health in general and by avoiding risk factor before or during pregnancy. These measures include smoking cessation, nutritional counseling, lower workload for women with a stressful job, diagnose and treat infection. The secondary prevention, screening test for early detection and prophylaxis. This is early identification, of pregnant women at risk of preterm labor and helped them to carry their pregnancies to term. These measures include self-measurement of vaginal pH for bacterial vaginosis and cervical length measurement by transvaginal ultrasonography. The prophylaxis against preterm labor include progesterone supplementation, cerclage or complete closure of the birth canal, tocolysis, and steroids therapy. The workup of preterm labor case. We have to answer some questions. The first question is the patient is in labor. The second question about the membranes, ruptured or not. The third question is the fetus preterm. The fourth question, are there is a risk factor present? The workup investigations and examination include to obtain maternal vital signs, general physical examination, sterile speculum examination, transvaginal ultrasonography, complete blood count, urine analysis, cervicovaginal swab, group B streptococcal culture, and C-reactive protein. The management of preterm labor. First, to start prevention of preterm labor, progesterone supplementation. In presence of short cervix with transvaginal ultrasonography, if there is a single-tone fetus and a low-risk group, vaginal progesterone offered if the cervix is 20 millimeter or less at or before 24 weeks. In the high-risk group, receiving progesterone since 16 to 34 weeks. Cervical cerclage should be considered if the cervical length is less than 25 mm before 24 weeks of gestation. If the short cervix with transvaginal ultrasound in multiple pregnancy, no intervention improves the outcome. Cervical cerclage is only indicated in cases of to prevent preterm labor only if history of 3 or more previous preterm or second trimester loss. Not offered if 2 or less previous preterm or second trimester loss. Ultrasonography indicative of cerclage if the cervix is less than or equal to 25 mm. Cerclage is not indicated if no history of spontaneous preterm labor or second trimester loss. VCQ cerclage, cervical dilatation more than 1 to 2 centimeter, with or without perceived uterine contraction, with or without membrane bulging. Women with single-tone pregnancy without spontaneous mid-trimester loss or preterm labor should not be offered. Ultrasonography indicated cerclage if the cervix is less than or equal to 25 mm before 24 weeks of gestation. The definitive treatment of preterm labor include bed rest and hospitalization, corticosteroid to enhance fetal lung maturation, inhibition of uterine contractions with tocolysis, treatment of infection with antibiotics, and neuroprotection. Corticosteroid administration recommendation by the Royal College of Obstetrics and Gynecology. Single-dose antenatal corticosteroid should be given to women between 24 to 34 weeks with high risk of preterm birth. Antenatal corticosteroid should be given to all women whom an elective cesarean section planned prior to 38 weeks of gestation. Corticosteroid therapy reduces the incidence of RDS, necrotizing enterocolitis, intraventricular hemorrhage, and sepsis. The recommendation of the Royal College of Obstetrics and Gynecology of tocolysis. only in those who benefit by gaining time to hospital or NICU transfer, neonatal intensive care unit transfer, or not completed steroid course. There is no clear evidence that tocolytic drugs improve outcome. Therefore, it is reasonable not to use them. Tocolytic drugs are not associated with clear reduction in prenatal or neonatal morbidity and mortality. Not recommended in suspected preterm labor who had otherwise uncomplicated pregnancy. So, tocolysis only in those who benefit by gaining time to hospital or neonatal intensive care unit transfer or not completed steroid course. Maintenance therapy in threatened preterm labor is not recommended. The candidate for tocolysis in presence of no drug contraindication, cervical dilatation less than 4 cm, healthy fetus, gestational age between 24 to 34 weeks, and confirmed preterm labor diagnosis. Contraindication to tocolysis: gestation more than 34 weeks, in utero fetal death, suspected fetal compromise, suspected intrauterine infection, labor is too advanced, lethal fetal anomalies, placental abruption, placental maternal hypotension, with blood pressure less than 90 mm mercury systolic. The relative contraindication to tocolysis: preeclampsia, placenta previa, placental abruptio, uncontrolled diabetes, cardiopulmonary diseases, multiple pregnancy, rupture of membranes, maternal hyperthyroidism, and sickle cell anemia. Tocolytic drugs that are used in clinical practice: calcium channel blocker, calcium antagonist, as nifedipine, oxytocin receptor antagonist, as atosiban, inhibitor of prostaglandin synthesis, indomethacin, nitric oxide donor, as nitroglycerin, beta-mimetic, terbutaline, ribitodrine, magnesium sulfate, COX-2 inhibitor, as nimesulide. Nifedipine and atosiban has comparable effectiveness. Compared to beta agonist, nifedipine improve neonatal outcome. Beta agonists have a higher side effect. Nifedipine, atosiban, and the COX inhibitor have lesser side effects. Comparing the effectiveness is unclear. Atosiban, it is only recommended by the Royal College to treat preterm labor. Atosiban doesn't alter uterine or fetal arterial blood flow pattern, developed to be uterospecific. It is a safe choice in multiple pregnancy, expanded blood volume, and anemia. The main adverse reaction is nausea. The maximum dose of the atosiban is 330 milligrams. The comorbidity and the interactions with atosiban: renal impairment is not likely to require an adjustment dose. Caution should be taken in patients with hepatic dysfunction. The safety and efficacy has not been established in pregnant female 18 years. No clinical relevant interaction found between atosiban, corticosteroid, or labetalol. The antibiotic use in case of preterm labor. In case of premature rupture of membrane, routine use reduce maternal and neonatal morbidity. The choice of antibiotic, any penicillin, except amoxicillin clavulanic acid, or erythromycin for 10 days. In preterm labor with membrane intact, the use of antibiotic is not at all recommended. Neuroprotection by magnesium sulfate. Administration of magnesium sulfate causes significant reduction in cerebral palsy in gestational age before 30 weeks. Administration even for multiple gestation. For expected delivery within 24 hours. Even in premature rupture of membrane, we can give magnesium sulfate. It could be administered 4 hours before delivery, according to the Australian guidelines. The management of progressive preterm labor, according to the American College of Obstetric recommendations. In the first stage, rest to preserve membranes. Electronic fetal monitoring is available. Mild sedatives only. Epidural analgesia if available. Hydration. Prophylactic oxygen advised. In the second stage, we have to use liberal episiotomy, but no evidence to establish this. No instrumentation as far as possible. Forceps application if there is fetal distress only. Immediate cord clamping to prevent blood overload. Third stage, more chances of delayed placental separation, so we have to wait and see. Don't pull the cord, it is fragile and thin, causing a retained placenta. Intravenous mesargine after placental delivery. Thank you.